Hello, I want to say welcome to Dr. Justine Waldman, who is one of our expert speakers for the Treatment and Emergency Department's Knowledge Lab coming up next week. Dr. Waldman, welcome. Why don't you start with telling us a little bit about yourself and the work that you do on this topic?
Thank you, Becky. Yes, so I the work that I currently do is I am the founder and chief medical officer, CEO of Reach Medical. We see ourselves as a health equity medical practice and primarily do work with people with opiate use disorder. Our whole model is based or is a harm reduction model and it's based on the evidence that buprenorphine is life savings. Most of our work is telemed and community based. And we have a very low threshold model for buprenorphine prescribing and naloxone prescribing and Hep C and a lot of other things. But we really do all of our work based in what's out there on the evidence.
Great, thank you. Can you talk to us a little bit how you got started in this work?
Yes. I guess it's probably my life's work at this point. I've always been interested in health equity. I locally in Ithaca, and I think it was 2005, I opened a free clinic, always working as an emergency medicine attending at the local hospital. And I became aware of this problem mostly through the actions of our mayor at the time and from the syringe service program that was local. And they had asked me to be a contractor for the first health hub, one of the first health hubs in New York State at a syringe service program. And I just loved the work and was able to really recognize that what was going on for people was this stigmatizing and not evidence-based approach to a chronic relapsing disorder. And so I think what's interesting about emergency medicine physicians to me is I believe that we cut to the chase very fast. And that's because we're seeing someone in the emergency room and you have to decide really fast. Are you admitting this person? Are you not? I don't know. What studies do I need to do to get there? And then you also have to figure out how am I going to market this person to get admitted to the people? How am I going to get what I need for this person? Because it's not always easy. And so I think it was easy for me to accept that what we were doing around opiate use disorder was stigmatizing, discriminating, and all the things it opened my eyes to all the things that had been happening in medicine that really were actually hurting these patients instead of helping them. So I opened up Reach. It's a nonprofit. We have about 10 to 13 providers, some full-time, some contracted. And we do just a ton of work in the community and all around New York State.
That's great. Thank you for sharing that background. So let's think about the topic that we're talking about during the Knowledge Lab, treatment in emergency department settings. Can you share with us your perspective on why we need to pay attention to this issue?
I have this bigger, broader view of what it means to do emergency medicine, especially in the United States. Basically, as a job, it's very fast paced. You're very much thinking in your mind, at least I was, you're trying to do the best for each patient that you're seeing. And you have 5,000 boxes that you have to click behind you. And unless the boxes become mandatory, some of them will fall off. In your mind, you can be thinking, it would be good if I sent this patient home with naloxone. But if the hospital isn't required to give out naloxone, it won't happen because at that moment that you think of sending the patient home with naloxone and it's not on your little drop down menu for discharge, you'll get distracted and send the kid home who needs amoxicillin, and then you'll forget. Even if it's on your mind, it's really hard, I think, with everything that's on our plate, regulation wise, to meet those things that we would like to do without it being set up for us to do it. And so my perspective is that what I know about the hospital setting is if CMS requires it, it will happen. If CMS does not require it, it will not happen. And until we get, because really what happens then is the hospital administration, once CMS deems that something has to be done or the hospital will be penalized, the hospital then rushes to get everything into the electronic medical record, everything into it all just becomes a click of a button. And if you don't click the button, then you have to explain why you're not doing it. So it actually makes things easier for people. It also makes another regulation, but I'm just shocked that there are so many things that CMS requires: aspirin before heart attack, 10-minute arrival for stroke, antibiotics for sepsis, and we don't require Narcan for discharge or buprenorphine out of the hospital.
Thank you, Dr. Waldman, for sharing that perspective. And thank you for taking the time to chat with us. We look forward to continuing the discussion during the Knowledge Lab on November 13th. Thank you for your time today.
Thank you.